on May 13th really address issues related to TMPRSS2 biology. Today, we're going to move into a number of clinical trials concepts that people globally are beginning to execute on. We look forward to data streaming into us and to the world in the very, very near future. My journey in this arena began in a Twitter conversation with Charles Ryan, Dr. Ryan, and Dr. Nima Sharifi, when they first discovered and thought about the disparity of men to women affected by COVID-19, by the coronavirus pandemic, and how that related to androgen and TMPRSS2, AR signaling in general. So this then exploded into a scientific, just a wonderful scientific umbrella. People all over the world during laboratory lockdowns actually found ways to get into the lab. If you had a chance to be at our first webinar, you would have seen this. Just today, a very talented writer for Science Magazine named Meredith Wadman. This report is about TMPRSS2 and COVID-19 is in Science Magazine. You might find it a very interesting read. So today we're going to speak about clinical trial protocols from around the world. But I'd like to begin by introducing Dr. William Dayhut. Bill, if you can raise your hand in the webinar. Dr. Dayhut is a senior medical oncologist, a GU medical oncologist of great success and strategic partner of the Prostate Cancer Foundation, as well as the entire medical oncology cancer community at large. From his seat at the National Cancer Institute, he provides a resource and wisdom on how cancer biologists, infectious disease doctors, radiation oncologists, just about every branch of medicine, including basic scientists and laboratories, can partner with the NCI to bring an end to the coronavirus pandemic. So Dr. Dayhut, thank you for joining us today. I would also like to introduce Dr. Charles Ryan, who is the head of hematology and oncology at the University of Minnesota, the Masonic Cancer Institute. We've asked Dr. Ryan to co-moderate with myself and my science partner, Dr. Andrea Miyahira. We've asked Dr. Ryan to give a brief overview on TMPRSS2 and coronavirus infection so that each individual clinical trialist and clinical scientist who will subsequently speak can just say ditto and don't have to repeat the introduction. So Dr. Ryan, welcome, and we look forward to your introduction.
Howard, thank you. It's really a privilege to be here with everybody today, and really another manifestation of why the Prostate Cancer Foundation is such a great community. Not only are we a great community in thinking about scientific challenges, we actually have one that landed at our doorstep in coronavirus. And I'm going to just walk through briefly some of the background, again, partly so that everybody else doesn't have to introduce it as well. But what began as a Twitter conversation about why men are being affected preferentially compared to women with coronavirus, and then a graphic that really showed up on Twitter about TMPRSS2 expression in alveolar epithelial cells started this. So by way of background, there is now a whole landslide of publications coming out about various different aspects of coronavirus. And I just pulled this from one of the recent papers. Of course, they're all recent, on infections and deaths. And this is a really nice table that demonstrates what looks like a fairly high preference, not so much in terms of cases, but in terms of death for men over women, or males versus females with regards to coronavirus death, with a ratio in the US in this publication of about 1.8 male to female. In Spain, it was 1.82, and in many other countries a little bit lower than that. So clearly a pattern that has been reproduced in multiple different countries, clearly worth thinking about what the mechanisms of that may be. So what was observed, of course, is that COVID-19 is able to bind to TMPRSS2, ACE2 complexes, which are located in alveolar epithelial cells and appear to be the predominant method of entry of COVID-19 into these cells, leading to infection. So this is what brings this infection and this story to our doorstep as investigators studying androgens and testosterone signaling and in particular the integration of TMPRSS2, which is androgen AR mediated, and that finding goes back now many years and is largely the fruit of Prostate Cancer Foundation funded research. So as we think about this in this complicated diagram, we really are confronted with the question of whether our prostate cancer tools can play a role. Is testosterone driving elevated TMPRSS2 expression in the lung, and thus would men with lower testosterone levels be less likely to be affected? So would androgen deprivation therapy be a potential treatment modality for this? What about targeting the androgen receptor itself? We now have a number of drugs that do this: apalutamide, enzalutamide, darolutamide, and bicalutamide, among others. And really the question is this the same type of signaling that would need to be inhibited with strong receptor blockers like an enzalutamide, or would a bicalutamide, for example, be sufficient in this regard because we're not dealing with malignant tissue? Also, camostat is a direct TMPRSS2 inhibitor. So what we're going to hear today are 8 presentations from investigators around the world who are exploring these questions. And as we do that, the questions that come to mind are, who are the patients we want to study? Are we going to study men in the ICU on ventilators, or are we going to study early post-exposure patients for prophylactic purposes? Which of these drugs would we want to use, and what are the endpoints that we want to see? I think as the world grapples with this infection, clinical researchers like us do grapple with these very questions and study design issues. And I don't think anybody can claim a monopoly on the truth as to how one conducts a COVID-19 study and what the endpoints are. So with that in mind, as our background, let's discuss this. And I believe we're going to start with Dr. Vinetz from Yale, who has a study of camostat versus placebo in outpatients. And so we'll be eager to hear what this is, and then we'll hopefully have some Q&A after these presentations.
Okay, so I'm on. Okay, give me a. So Howard and Andrea and everybody, thank you for inviting me. I'm really glad to be here. I've been in touch with Ole and Alan Bryce and others, which is how I've gotten here, and I'm really grateful for this opportunity. I came to doing a clinical trial for COVID-19 after seeing hundreds of people at the Yale New Haven Hospital and realizing first that I couldn't do anything meaningful, and second, I found out that most clinical researchers in universities start out with sponsor-initiated trials rather than investigator-initiated trials. So I was very naive going into this, and with a lot of support at my own institution and this community and some others, I've been able to come up with a clinical trial based on camostat and the camostat biology, and you can see the title here. And I have no disclosures or conflicts of interest.
I don't see your screen. I'm sorry.
It says it's sharing. Let me try. Oops. Let me try again.
And just to remind everyone who's attending that you can ask questions on the QA, and at the end of the presentations, we'll choose questions and have our speakers answer questions.
There you go, Joe. We see it.
Okay. So just call me Joe. That's a lot easier. Again, I have no conflicts. So building on the basic biology of TMPRSS2 and SARS-CoV-2 infection, and I'm an infectious disease physician at heart, we look at the natural history of infection, and we have a bias that we think that if we prevent the virus from replicating up here, we will prevent all of the bad disease manifestations down to the right. We don't actually know that. We hope so. And so a lot of our presumptions are that early antiviral therapy will forestall complications. And that's the basis of our clinical study design. And so the design is a randomized double-blinded placebo-controlled use of chemistat mesylate. The FDA has approved this particular study, and in 2 days we will be recruiting with the hypothesis that there's going to be an in vivo antiviral effect on SARS-CoV-2 in humans, and the antiviral effect will diminish clinical signs and symptoms and complications. The ultimate study population is outpatients. We're focused on early infection, and we have really a two-phase study of 600 COVID positive patients who will be recruited within 3 days of positive testing. It will be study drug versus placebo. The placebo will be made by our research pharmacy. We're working with Ono Pharmaceuticals, who's providing the drug for free, but not a matching placebo. The study design is really two phases. Of the 600, we have two interim analyses, a safety analysis at 50 patients and a virological outcome at 114 patients, which has been calculated based on expected viral changes from baseline to 4 days, of 1/3 of a log, basically. The sampling that's essential for the outcome for the first phase is doing nasopharyngeal swabs and taking a collection of every other day swabs and running them on the machine at the same time with the same protocol. So we're looking at within patient changes from baseline to day 7 after enrollment. We'll also be getting daily symptom scores, clinical assessments, pulse ox, et cetera, which I don't want to go into too much detail on. And the primary outcome for the N of 600 is a risk for hospitalization, complications, disease progression, et cetera, with an interim analysis for safety, as I noted. That N is supposed to be 114. That was a typo, I'm sorry. And the idea is if there's no virological improvement from baseline to 4 days, then we think that there will not be an antiviral effect that will be particularly meaningful given the viral dynamics that we know about. So that's the basic trial design. And building on that, there's a lot of biology that we need to know. First of all, because we have a placebo control, we are going to be able to look at the natural history of the immune responses in COVID-19. We can look to see basic questions like, is antibody protective? That's a very hard thing to do and needs longitudinal follow-up. What about in vitro studies? Does that predict protection? And that's also a complicated topic in terms of titers. How do we assess neutralization titers for infectious virus, which requires BSL-3? Are there T-cell responses that actually determine protection rather than antibodies, which could be simply an epiphenomenon? We do not know the answers to these questions, and the study design will enable longitudinal follow-up for at least a year or longer. Second, will early treatment prevent progression of pathogenesis, prevent progression of pathogenic mechanisms, and therefore the clinical consequences? For example, respiratory outcomes, but we also know that there's important thrombovascular disease processes, including coagulation problems, as well as endothelium-related diseases, which is all very complicated. So the best clinical research, in my experience, will be able to assess an outcome of a drug treatment but also be able to look at the biology of disease. And so that's me, and that's all I really wanted to say. That's very brief.
Joe, thanks. Great presentation. I think what would be good to do is do all three of the chemostat presentations and then have a Q&A on the chemostat question, perhaps. And then we'll move on to the hormonal studies, if that's okay. So then we could move on to Ole Sjogard from Aarhus University in Denmark.
Sure, I'll just unmute myself. Thank you very much. And once again, thank you very much for the invitation to participate in this meeting here. I'll just pull up my slides. 1 second. There you go. All right. Do you see my slides?
Yep.
Yeah, good. Okay. So we also were quite interested in studying chemostat in COVID-19. So right after the paper by Hoffman et al. Came out in Cell, we pursued whether or not we'd be able to obtain the molecule from Japan, and we were quite fortunate to quickly get a deal with Ono Pharmaceuticals and import the drug quite rapidly. So the title of the trial is The Impact of Chemostat Mesylate on COVID-19 Infection. And really it's two studies in one, so I'll just show you in a second. So the background you already went into, so I'll not spend any time on that, except just highlight that chemostat, compared to some of the other repurposed molecules out there, actually inhibits a known mechanism for cell entry of SARS-CoV-2. So the study design of our study, which is called COMOCO-19, is quite simple. Basically, I modeled the study design based on how we treat influenza. I'm also an infectious disease physician and a researcher. So for influenza, we treat with Tamiflu for 5 days. So we also chose a 5-day dosing period with chemostat. Basically, we start treating as soon as possible after patients are enrolled. We do blood sampling and swabs on day 0 and 5, and then patients receive 200 milligrams 3 times daily for 5 days. In cohort 1, we enroll patients that are hospitalized, and here the target is to enroll 180 patients. In cohort 2, which is outpatients, the aim is to enroll 400 patients. Both cohorts receive the same treatment regimen, but obviously the monitoring and the sampling is somewhat different because it's easier to basically sample and monitor inpatients compared to outpatients. So the inclusion criteria for the hospitalized patients are, of course, documented COVID-19 infection based on a PCR result. We would like to enroll patients that have been admitted at most 48 hours before being tested positive for COVID-19. We are aiming to enroll adults, and of course, they have to be able to consent to the study. So we exclude patients with an eGFR below 30 and with a SAT or LAT 5 times above the upper normal level. We start enrollment on April 4th, and we have 10 sites enrolling in Denmark, so 10 different hospitals. The primary endpoint is based on the first study that came out from China that used this ordinal scale, a 7-point ordinal scale, basically based on clinical improvement. So clinical improvement is graded from being completely healthy and well up till the highest 7-point, which is death, and anything in between goes from ICU and then to different kinds of oxygen treatment, to need no treatment, and to being discharged. Secondary endpoints, I just listed some of them here, but they are more or less the same as in many other studies focused on hospitalized patients. So basically having a a standardized evaluation on specific days, 7, 14, and 30. And of course, also looking at mortality and admission to the ICU. So in the outpatient study, we look for patients that have had a short duration of symptoms, no more than 5 days, and test positive for SARS-CoV-2. These are patients that either have one of or more of the symptoms listed here: fever, cough, expectoration, shortness of breath, myalgia, fatigue, or headache. And again, adults above 18. The endpoints here are somewhat more challenging, as Joe just alluded to, because these patients are not sick enough to require treatment. So of course, some will be eventually admitted to hospital, most will not. So we use a similar days to clinical improvement kind of endpoint, but it's based on the symptoms rather than on being discharged from the hospital, of course. So it's being free of fever and having improvements in the other symptoms. Secondary endpoints are, of course, admission to hospital, but also when the patients report to be healthy and whether there are secondary infections within the households. Okay, I think that was basically it. So just to give you kind of a brief status of where we are. So we've been enrolling now for exactly 2 months today. So we started out really well. We had the epidemic was, as in most places, peaking when we started enrollment. But the situation now in Denmark is that a lot of things have opened up. Schools have opened up, non-essential businesses, but the infection rate has just gone down and down quite considerably. So we are down to less than 20% of the hospital admissions that we had when we started. So obviously recruitment has slowed down quite considerably. We are negotiating with several hospitals in Sweden to start enrollment there because, as you might know, they have been better than us to keep the epidemic going. So they actually have quite a lot of patients still.
Very good, thank you. Again, we'll get to some Q&A after Dr. Bryce's presentation. So the next speaker is Dr. Alan Bryce from the Mayo Clinic in Arizona, who has a randomized trial of standard of care with Camostat or placebo in hospitalized patients with COVID-19.
Sorry, I had to unmute myself first. I apologize. Get back to my presentation. All right, so thank you to the PCF for having me on this webinar. As you've heard from the last 2 speakers, we know that there's a rationale for using Camostat in patients with COVID-19 infections. So much like the previous presenters, when reading the Hoffman paper, we decided to try and pursue obtaining Camostat, and we're able to receive an agreement with Ono Pharmaceuticals in Japan to provide the drug, because Camostat mesylate is a drug that's been available in Japan for decades now for the treatment of chronic pancreatitis and gastritis. So it's a drug with a very well-known safety profile and many years of experience. So our study that we proposed and for which we do now have the IND is looking specifically at inpatients and looking at a randomized trial of placebo-controlled randomized trial of Camostat or placebo with standard of care for hospitalized patients. And whereas we did initially design this around the WHO ordinal scale, much like the other studies. After submitting to the FDA, they really preferred that we look at a 28-day endpoint, looking at a combined rate of respiratory failure and death. And so that's how the study's been redesigned. So what we have is a randomized trial, 1-to-1 ratio of 276 patients hospitalized with COVID-19 infection. will be stratified on the basis of disease severity using the WHO ordinal scale, which I'll show you in a second here, as well as age, that being a known, obviously, risk factor for death, as presumably everybody knows. And the endpoint is that combination of being free from respiratory failure and alive at day 28. Secondary endpoint, somewhat more stringent, saying free of ventilator use or ECMO at day 28. And then slightly longer term outcomes looking at all-cause mortality at days 28 and 60. Also, as you see with the other studies, there'll be virological assays. In fact, the intent, and again with FDA input, is to be very comprehensive in doing nasopharyngeal, oral, serum, and stool assays for viral load. This is the WHO ordinal scale, just a slight variation on what was used in the remdesivir study and the 7-point scale that you hear otherwise inverted, 1 extra point. But the definition of respiratory failure then is those sections in orange there. So non-invasive ventilation or high flow oxygen. So 5 or above would be respiratory failure. 4 below would be free of respiratory failure. So oxygen by nasal cannula is permitted. We would include, or we do include, both a combined efficacy and futility analysis at 50%, 75%, and 100% enrollment, or 100% of course being the final analysis. And this will be also a safety assessment by the DSMB. The intention, this will be open across the Mayo Clinic academic sites in Minnesota, Arizona, and Florida, as well as the Mayo Clinic Health System hospitals in western Wisconsin and southern Minnesota. But more specifically, this is really being driven out of Mayo Clinic, Arizona, here in Phoenix. And our intention, our conversations with all the local hospitals, is to open this as broadly as possible across the community hospitals in the state of Arizona, where Mayo Clinic will act as a central IRB and as the CRO for all the Arizona hospitals. What I put here is showing the cumulative, or not the cumulative, the daily inpatients in the state of Arizona going back from early April to now. And you can see, in fact, in Arizona, our rates, our total disease burden is still rising. This is largely driven by the really terrible outbreak on the reservation and amongst the Navajo Nation. And so in the state of Arizona, our hospital coalition spread to the patients kind of across the state so that no one hospital is overwhelmed. But we also see at the same time that the test positivity rate is going up, despite the increase in total assays being done statewide. So in Arizona, our infection rate, our disease burden, unfortunately, is getting worse, not better. And so we have a slightly more urgent motivation, I suppose, to really do this. Now, we don't have drug in hand yet. It's being shipped, making its way through customs. Our placebo is also being commercially supplied. So we're a couple of weeks out from opening. But I have no doubt that unfortunately, we're still going to have the patients to need to treat. I will release it back there for questions.
Thanks, Alan. I'll turn it over to Howard now.
Before we move forward, I'd just like to go back to Bill Dayhut for a moment. These are some really interesting clinical trials compared to oncology trials. They've opened quite quickly, I would say. And there's going to be more that people are going to present. But at this juncture, I'd like for you just to say a few words of how people like these researchers can interact with NIH.
Yeah, thanks, Howard, and thanks, Andrea. I think we're really fortunate to have Ned Sharpless and Jim Dorshow in NCI leadership positions. And from the beginning, Ned's really focused on what should the Cancer Institute be doing. He's also sensitive to the idea that cancer investigators, if they take a veer too far away because of sort of the urgency, could have an impact on their career. So there's real sensitivity. So I think the two areas that I think he's most interested in supporting are either cancer patients with COVID-19 or drugs or targets in which we have experience. And I think that's why this discussion is so pertinent, because obviously we're talking about a target that has largely been worked on for years, at least the androgen part, by cancer physicians. So Jim Dorshow and Meg Mooney in the at CTEP are really sort of driving the clinical trial infrastructure. You know, they've already done a supplement to a cancer center grant for sort of a TMPRSS2 enzalutamide trial from a small laboratory in Michigan that I will be nameless, but you may guess what I'm talking about. And then in addition, there's been increased flexibility on the trials, on the CTEP studies. You'll see on other CTEP studies where telehealth is now being allowed. There's flexibility about drugs that are not investigational drugs being sent to other sites. And there's also, you know, the ability to have some flexibility in trial design. So trials which have been opened up relatively rapidly for the NCI was sort of an expansion of an anti-IL-6 drug for cancer patients. There's an acalabrutinib trial that's an intramural trial that's based on some BTK evidence. You'll see a paper tomorrow in Science Immunology. But there's really a lot of excitement and interest in getting trials out quickly. And so working with Meg and working with Jim really makes sense, particularly where it's sort of a longer term cancer focus, whether the drugs or the target or the patients. And I think that would really be my recommendation at this point.
Thank you very much, Bill. Chuck, back to you.
Thank you. So these three presentations all focused on Camostat and have very similar but somewhat distinct designs. And there's a lot of questions in the Q&A and the chat feature. And I would encourage people to use the Q&A feature for their questions, not the chat. And we'll read some off of there. You know, one question that came up as I was looking at these designs is the issue of stratification and these moderately sized trials, and what we're reading about comorbid illness and how it drives morbidity and mortality from COVID-19. How are the three of you handling the issue of potential variations in comorbid illness, and how are you directly addressing the issue of male versus female in your studies? Alan, I'll start with you.
Yeah, thanks, Chuck. I mean, the male versus female question, you know, we went through about 11 different iterations of this study in about 72 hours as we, you know, started to talk about what we wanted to do and how we were going to launch it. And, you know, obviously using Camostat is different than perhaps what we'll hear in some of the next presentations where there's more of an AR targeting strategy. The Camostat hypothesis, I think, is not gender specific, right? Now, in terms of stratification, I mean, this is really mostly a statistical conversation on our end. You know, how many stratification factors can you have in a 276 patient, you know, randomized trial before you lose power? So that's why we decided to focus simply on kind of the biggest, most important items. But without question, you know, there is going to have to be an analysis after the fact to make sure that we were balanced in terms of comorbidities, you know, balanced in terms of gender. But statistically, we just didn't feel that we could, you know, really have 5 or 6 stratification factors. Couldn't do it.
Understood. Ole, do you have a response to that question?
Yeah, I completely agree. It's a great question. And I think as highlighted by the recent remdesivir studies, where they in some studies do adjustments and in other studies don't, I think it's quite important that we try to balance the baseline variables as best as possible. But I'll completely agree with the others that there are limited possibilities for doing major adjustments in a fairly small sample size. So I was just thinking the other day whether at some point when all these trials are done that it might be worthwhile to basically pool all the data and then do maybe more comprehensive analysis across the different data sets. I know that some of the inclusion criteria may differ a bit, but I think it's still worthwhile to at least consider. So I agree, gender is not the thing I'm most concerned about being imbalanced. There are other things that, I mean, just by chance having sicker patients in one group as seen in the 5 versus 10 days remdesivir study, that actually made a pretty big impact on the endpoint analysis. So, yeah.
Joe?
So my approach has been really, is there an antiviral effect? And so it's fundamentally different. And so we're doing consecutive patients. So there should be, and they're allocated in a block randomized way. So we think that, there should be a fairly equal distribution of comorbidities. In our experience, we don't have many asymptomatics, and that in the New Haven area, there's a lot of racial diversity and comorbidities, especially obesity, diabetes, hypertension. And so by taking consecutive patients, we should be able, and block randomizing, we should be able to get rid of any of those confounders, but we'll find out how equal when we have a table 1 afterwards. And then the virological outcome is not a clinical outcome, so that gives us a smaller sample size to start with.
Right. That makes perfect sense. Could you address, there's been a couple questions about what are the risks of Camostat? It's not a drug that we are directly familiar with in oncology, and what are some of the side effects that patients may face?
Who do you want to answer that?
Go ahead, Joe. You're still on.
Right.
Go ahead.
So I've never given the drug. The reported safety profile is remarkably safe. There are these occasional, very occasional case reports of pulmonary eosinophilia and respiratory. I think basically they can be it's given for pancreatitis primarily and post-operative reflux. And so people have belly pain to begin with. And for sure, in the extensive data that Ono Pharmaceuticals provided, there's still a relatively low, less than 1% incidence of any abdominal complaints, and then uncommon to uncalculatable adverse effects like hyperkalemia and whatnot. That's kind of my understanding, that the adverse effects are very uncommon, and severe adverse events are nearly unseen. That's my impression. We'll find out.
Okay. Other questions that are coming through: is anybody doing genetics of TMPRSS2 on these clinical trials? I presume either from lung lavage tissue or something like that, or I don't know if there are germline variations that would be looked at. Is that something that is known? Is that something that you're looking at? Genetic alterations of TMPRSS2?
We're not planning to do it.
We're thinking about doing buccal scrapings and looking at expression levels with and without Camostat, with and without, or versus placebo. I looked in the literature; it hasn't been done. But that, again, I'm just a poor country doctor doing infectious diseases. So this is all a voyage of exploration for me. I don't think we should be doing prostate biopsies, though. That might be considered uncomfortable.
Yeah.
Chuck, there's a question from a PCF board member on the timeline for an efficacy readout on these clinical trials. If you can just sort of give us a relative case estimate of when you think you will know if it's positive or not.
Sure, I can go first. So when we start enrollment on April 4th, we estimate that it would take approximately 2 or 2.5 months to enroll. Obviously, the infection rate has gone down, so it really depends on whether or not we'll be able to expand beyond Denmark to Sweden. If so, I'm optimistic we'll be done by August. If not, I think we'll have to wait till the second wave, basically. So if there will be a second wave.
Yeah, you said that with such confidence that you'll have to wait for the second wave. What do you think as an infectious disease doctor?
I
think it's a great question. So I think there's a good chance we'll see an uptick in the number of cases in come November. But with the intensive screening going on, at least in Denmark, anyone can walk from the street and get tested by PCR. I don't think it'll be as intense as it was when it started here in March.
Joe, were you going to say something?
So we're using the outpatient drive-through screening system and we may be doing some partnering with some other health systems for screening. And so right now, as of last week, there were 25 to 50 new outpatient diagnoses daily, 7 days a week. So it's really a matter of recruitment. I think we're limited more by recruitment coordinators than we are by patients at this point.
Who is your team, by the way, your clinical team? Is it from your clinical trials office at your cancer center, or is it, yeah?
Well, that's been repurposed actually, because the outpatient cancer trials have kind of stopped. I think they're going to be starting up again. But the Yale Center for Clinical Investigation, which is mostly cancer, some cardiology, some diabetes, has been repurposed into COVID. It's kind of all COVID all the time for them. And so we have that full clinical trials network.
Alan, you want to comment? You showed your accrual, you showed your incidence data, and your study's about to open. Do you have special provisions in place for cancer patients who go on these trials? Do you want to speak to this issue of cancer patients going on to the CAMSTAT trials? I know that there have been cancer centers that have been focused on this question directly.
Yeah, so in terms of opening, I think we're probably 3 weeks out from getting first patient on. And so I was kind of hoping or expecting Ole's data will come out first, and I'd be happy to see it, right? But, you know, from there, if the infection rate stays the way it is in the state, you know, I think 2.5 months or something, right? But the variable is what is the, you know, what is the prevalence? And of course, if it slows down, if we have an experience like they have in Denmark, then it'll take longer, which would be great, right? In terms of cancer patients, it's not a specific provision. You know, here we are screening all of our cancer patients, who are, at least those who are on treatment, and it's about a 2 to 3% positivity rate. Almost all of them asymptomatic. We've had 2 inpatients so far, so very few actually cancer inpatients. And again, it probably reflects where our real virulence population is coming from. So I expect the cancer accruals to actually be fairly small, right? This is not a cancer-specific study.
Sure, right. And I think William O. and others may address this question as well. So this has been a great conversation about CAMSTAT. And what I want to do is move on to the next presentations, which are focusing on the AR and the ADT aspect of treating COVID-19. So our next speaker is Nicholas Nichols from the University of California, Los Angeles at the VA Greater Los Angeles Healthcare System. He's going to talk about their study of hormonal intervention for COVID-19 requiring hospitalizations. Go ahead.
All right. Oh, thank you very much. Very good. Can you see my slides? All right. So I'd like to thank the PCF for the opportunity to present on behalf of the HITCH trial team. Our trial is hormonal intervention for the treatment of veterans with COVID-19 requiring hospitalization. It is a multi-center phase 2 randomized controlled trial of degarelix versus placebo. So this is an overview of the trial. So the patient population are male veterans, only male veterans who have been hospitalized due to COVID-19 and with a level 3 to 5 disease severity on the influenza severity scale. So that means they are hospitalized and they may or may not require supplemental oxygen, but do not require invasive mechanical ventilation. They are randomized 2-to-1 to degarelix versus placebo, and they are stratified by age, greater or less than 65, presence or absence of hypertension, and severity level. The primary endpoint is a composite of mortality, hospitalization beyond day 15 after randomization, or any need for intubation or ECMO, and we have a number of secondary endpoints. So this is a trial that is open at many PCF VA prostate cancer centers of excellence, including the VA Greater LA, which is the lead site, the VA New York, Manhattan, and Brooklyn sites, VA Puget Sound. The VA in Chicago and Philadelphia will be also joining soon. The trial is sponsored and funded by the VA Office of Research and Development. And data management is via help from the VA Cooperative Studies Program Coordinating Center. Matt Reddick is actually the chair of the trial. I am the co-chair. And the objective is to determine if temporary androgen suppression from daguerreolex can improve clinical outcomes of veterans who are hospitalized in acute care ward at a VA hospital as defined by a reduction in mortality, extended hospitalization, or requirement for invasive ventilation. So the study treatment is daguerreolex times 1 month depot. So it is a one-time loading dose, essentially a 28-day dose of daguerreolex or matched placebo that is generated by the pharmacies. And why daguerreolex? Here's some rationale. It's a one-time administration. It's rapid acting. So essentially within a couple of days, the vast majority of patients will achieve a castrate level of testosterone that's robust and consistent, has a well-established side effects profile as well. A little bit more about our endpoints. So the primary endpoint was selected to offer a clinically meaningful endpoint that is a composite of inpatient mortality, ongoing need for hospitalization beyond day 15 after randomization, and any requirement for mechanical ventilation or ECMO. So a patient is considered to be a success if the patient is alive, did not require mechanical ventilation, and is no longer hospitalized at day 15. So an event is essentially a patient dies, is hospitalized past day 15, or requires that ventilation at any time. We also have a number of secondary endpoints shown here, many of which are similar to the other endpoints on trials that have been discussed, including time to clinical improvement, duration of hospitalization, et cetera. We also have a number of exploratory analyses planned to identify the impact of various clinical and laboratory prognostic factors on the primary and secondary endpoints. And we also have some translational investigations that aim to quantify TMPRSS2 expression via nasopharyngeal swabs and viral load in the nasopharyngeal swabs and in the blood. We are doing these correlative analyses only at Greater LA due to the other sites not being able to conduct them. And the inclusion criteria is shown here. Basically, the trial targets veterans who are hospitalized due to COVID-19 and not requiring invasive mechanical ventilation. Point out that actually testosterone level is not a part of the inclusion criteria. Rationale for that is the turnaround time on that test can be a day or two. There isn't time to wait for that to result. And while there may be some impact on viral infection on testosterone levels, the data that's out there does not suggest it's significantly different, and certainly not at the level that would be expected of a androgen suppression. Here are some key exclusion criteria that I'd like to point out. So the hydroxychloroquine and chloroquine are not allowed within 30 days of randomization nor on the trial. There's concurrent use of other antiviral therapy directed against SARS-CoV-2 is not allowed, with the exception of remdesivir, which is allowed. And that was a trial protocol modification that we did after the data for that has come out. And the patient cannot be planned to be discharged within 24 hours. Additionally, patients with long QT syndrome or concurrent use of drugs that prolong the QT interval are also not allowed. Notably, the use of convalescent plasma is allowed. A number of veterans actually in VA actually do get that, and that is an allowed therapy. So this is information on our sample size. We assumed an effect size of 42%. Basically, that 60% of the control arm would have some event, meaning they would be hospitalized past 15 days or require invasive ventilation or expire, and 35% of the intervention arm. The allocation ratio is 2-to-1 in favor of daguerreolex, and 186 evaluable patients are required with an attrition rate that comes to 198 patients to be enrolled. We have a planned interim analysis when essentially half of the patients complete the study, and it will be assessed for evidence of efficacy or futility. The monitoring is done by the VA Cooperative Studies Data Monitoring Committee, as is typically the case for VA CSR&D trials. We have designated certain AEs to be of special interest. They are any CTCIE version 5 grade 3 to 5 toxicities related to hypercoagulability or arrhythmias. And there is, in addition, a toxicity analysis that is automatically triggered when 25% of all enrolled patients has an AE of special interest, and that triggers an automatic toxicity analysis by the Data Monitoring Committee. And this is the HITCH trial team members, includes investigators from multiple VAs in medical oncology, radiation oncology, critical care, infectious disease, the cooperative studies group that has been extremely helpful with IND submission and data management. And that is it.
Okay, thank you. Again, we'll put your questions on the Q&A feature. There are a lot coming in, which is good. We'll go over them at the end of this section. I'm going to go on to Dr. Andreas Josephson from Umeå University Hospital in Sweden, who's studying enzalutamide in patients hospitalized for COVID-19.
Thank you very, very much for the invitation to be able to present our trial that we have been working on. It's an investigational initiative, and we have had sponsoring from Astellas with unconditional grants. I will come to that later. The trial name is COVIDenza. And this is like the other prospectively randomized multi-center clinical trial. And we will compare enzalutamide versus standard of care to decrease morbidity of COVID-19. I'm working assistant professor and the consultant urologist in Umeå and also in Gothenburg, actually, at the Sahlgrenska University Hospital as well. The trial design is that we will include patients with SARS-CoV-2 positivity. We will include men and women. The randomization will be stratified for both site and for gender. Randomization will be 2-to-1, and the enzalutamide plus standard of care will be only for 5 days with enzalutamide. And we will not have a placebo-controlled trial because of the problem to get the placebo pills. So that we actually needed to otherwise wait for a couple of months before we could have that arranged. So we decided to have like standard care in the control arm. The inclusion criteria is then positivity of SARS-CoV-2. We will have mild to severe symptoms of COVID-19. They will be hospitalized. They have an ECOG performance status between 0 to 3, and we have decided to have an age limit of 50 years or above. The exclusion criteria in this trial, we have the normal way of allergy to enzalutamide if we will find someone, if they are pregnant or breastfeeding, need of immediate mechanical ventilation. These are, like you said in other trials, that if they are in need of this immediately, we will not include them. Well, if they have any treatment with hormonal therapy for prostate cancer or breast cancer, they will be excluded. Anti-HIV medicine, immunosuppressive agents, or warfarin. We have also excluded patients with medical history of immunosuppressive disease, stroke, transitory ischemic attack, unstable cardiovascular disease, and seizure.
Yes.
We have, okay, sorry, you don't see the full picture here. Sorry, maybe I should do this for presentation view instead. I'm sorry for that. Now you see better, sorry. So exclusion criteria we have gone through. So the trial design is like the other. You have said that after the first 45 patients, we will have like a safety analysis. So we will have 2 interim analysis on the trial. We have possibility to scale the trial for up to 600 patients. So we will perform a novel power calculation after the first 100 included, and so that we will know where we should end up in the inclusion criteria. We will also, after 100 patients, we will also ask the Data Safety Monitoring Board to also evaluate if there is any difference in the treatment arm between men and women, so that we will maybe need to change them with an amendment if we should have any difference in recruitment. So the schedule of events in the trial is quite fairly simple. I mean, the infection clinic is very hardly burdened with what to do, and so we have scaled it down so that for the first 6 days we will have enzalutamide treatment from day 0 to 4, and then we will have until day 6 we will have every second day clinical parameters, and then based on this 7-point ordinal scale, the adverse events, and for the first 45 patients, we will also include PCR tests for SARS-CoV-2 every second day. And we will also have a higher amount of different kind of laboratory assessment for the first 45 patients. Then we will follow the patient every week and see what is happening, and until day 30, and then they will come back at day 45 and also at 6 months. Basically 6 months is mostly just to see that there is no long-term adverse event, and also to look at serological immunity. So this assessment of clinical status you have already seen. We will use the 7-point ordinal scale. So the primary endpoint in the study is time to intensive care unit admission. That is in Sweden mostly used by ordinal scale 6, and or the other primary endpoint is time to discharge. Secondary endpoints that we will evaluate is, of course, the safety evaluation, duration of supplementary oxygen, laboratory assessments, hospital stay, readmission to hospital, mortality, and then serological immunity. We will also look at testosterone and estrogen, both at baseline and also at 6 months, actually. The timeline for this trial, it has gone very quickly, as in all cases. We proposed the idea to Astellas portal for investigational suggestions, and then we had actually acceptance at April the 12th. We had the Swedish Ethical Review Authority approval on May the 15th, and we have had the answer from Swedish Medical Product Agency, and we have answered them, and we are now just waiting this week for having the answer to start the study. We have planned trial start. The first trial start meeting is on Monday. And the Covidenza initiator is me and Karin Belén, a researcher in Gothenburg. And then we have these infection disease doctors in both Gothenburg and Umeå, Claes Alm and Magnus Gisslén. This is actually, in Sweden we have a clinical trials in urology for many years in prostate cancer. For instance, this SVCD trials that I'm also involved in. And during this network, we have called to everyone we know at the urology in different clinics, and then we have asked them to find some infection clinic doctors to kidnap and to go along with this trial. So we actually managed to have all these centers ongoing to start. We will start next week with 3 trials initially, probably 4 trials, 4 sites next week. So that is what we are working with. And thank you very much for listening. And as I said, we have the financial support of Astera Pharma. And we also have, during Wallenberg Center for Molecular Medicine is where I'm working as a group leader. And I also have permission to use the funding from them in this trial. The contact information, I will be glad to discuss this further on our website, or you can also reach me by mail, of course.
Excellent. Well, I'm going to look forward to hearing a little bit more about the situation in Sweden. I think it's attracting a lot of attention, and will be very interesting to get your thoughts on that. I want to transition to Dr. Gillison, Silke Gillison from Switzerland, the Istituto Oncologico della Svizzera Italiana, who is conducting a randomized trial of standard of care with and without enzalutamide with a very similar design. We'll be looking forward to contrasting these 2 studies. Silke?
Yes, hello. I hope you can see it.
Yeah, maximize it. Do the show mode, right?
I just tried. Yes.
There you go.
Okay. So yes, so we're also testing enzalutamide in a randomized open label phase 2 study, but we are going into, again, outpatients here. And also here, this is a collaboration with a lot of people. Dr. Pereira will be the PI, and there is cardiologists involved for the electronic home monitoring, and also infectiologists, and obviously our colleagues from the lab. And you have probably all heard Andrea Alimonti, who has actually given the idea to do this trial. So this is our trial scheme. So again, we are really having patients who have also a very short time from onset of symptoms and who have no indication for hospitalization. So all outpatients. But they have to have at least one risk factor for complications. And these risk factors, as we all know, are age above 65 years, diabetes, hypertension, cardiovascular disease, active malignancies. So here come our patients in, and chronic pulmonary disease. And the patients are randomized 1-to-1 to receive enzalutamide for a maximum of 28 days, but also just when they have a second negative, so a confirmed negative PCR. And the other arm gets a standard of care. So our primary objective is a bit different. So we're looking for decreasing the viral load. We have secondary objectives. There we go for clinical signs, controlling disease progression, controlling fever duration, and also to look for safety in these patients. And with our colleagues from the lab, we have some translational objectives, serologic response in the two arms, virus load with droplet digital PCR in the nasopharyngeal swab, viral load also in the serum, and TMPRSS2 expression in plasma. And the primary outcome, so how are we measuring it? We're looking for the difference in percentage of negative patients in the quantitative RT-PCR from nasopharyngeal swabs at day 5 in the two arms. For the clinical, we're looking for a composite of hospitalization, invasive mechanical ventilation, or death within 30 days in the two arms. So the inclusion criteria, very shortly, again, we try to have patients who have a short time since the onset of symptoms. We are looking for outpatients who have mild symptoms, but are at high risk for complications with at least one risk factor. And as exclusion criteria, we have females and patients requiring inpatient treatment. Our number of participants is 90, 45 per arm. The treatment duration will be, as we discussed, a maximum of 28 days with enzalutamide, and the estimated trial duration is about 7 months because we have 6 months of follow-up. Our first participant is planned in July. We just made the submission to the ethical committee yesterday, so we hope it's also going very fast. And like a little bit like in Denmark, in Switzerland, and it's obviously very good, our infection rate has gone really drastically down, but we think that we could be finished in 1 year, and then obviously with the follow-up, having the last participant out in December 2021. So this is our schedule. And as we have seen before, we do a lot of nasopharyngeal swabs because this is our primary endpoint. And you see this here. And with that, I thank you for your attention. And I found this dandelion looks a little bit like a coronavirus. So thank you very much.
Thank you, Silke. Our next speaker is in the endocrine category, if you will, is Dr. Catherine Handy-Marshall at Johns Hopkins, who's doing a phase 2 study to promote recovery from COVID-19 with ivermectin or endocrine therapy, the RECOVER study.
All right, thank you so much. Can you see my slides okay? All right, thank you. So we're going to be enrolling 60 hospitalized patients, randomized 1:1:1 and stratified by gender. Our patients will be treated with bicalutamide, 150 milligrams daily for 7 days. Arm 2 is ivermectin treatment for up to 6 days, and arm 3 is the control. I do want to note there's no scientific overlap with ivermectin, but because that team had similar inclusion criteria, and also from our institution, we joined efforts to utilize a shared control group. And our primary endpoint is based on clinical improvement by the WHO scale at day 7. So the rationale for using bicalutamide as opposed to some of the other agents, we do think that the upregulation of estradiol is also important. Because of the feedback loop on the hypothalamic pituitary axis. We know that estrogen levels do increase within a week of therapy. And there's been some work out of Hopkins that shows that that's associated with improved outcomes in acute lung injury. So Vasan Yeghnasubramanian, who's a prostate cancer research in collaboration with some of our pulmonary doctors here, have been looking at a mouse model of strep pneumonia-induced acute lung injury, and have found that treatment with estradiol results in a decrease in bronchoalveolar lavage protein levels, a decrease in neutrophil levels, and then an increase in T regulatory cell numbers. And that corresponds to improvement in the histology that you see too, with treated mice having resolution of their acute lung injury, as you see in the top right. And I think that this is mediated by T regulatory cells. So in panel E, you see that the mice who are depleted of Treg cells and are treated do not have resolution of acute lung injury, although the wild type mice who are treated do. The other big things are cost and availability. So the cost for the entire trial for bicalutamide is a little over $100, and it's internal funding that we're using for this trial, and then it's obviously widely available. So our inclusion criteria, we're using adult men and women who have COVID-19 infection and then do require inpatient hospitalization, but with minimal respiratory symptoms. So have to be on less than 6 liters of oxygen and a respiratory rate of lower than 30. I'll mention why we're including women. So even though women have lower testosterone levels, the range of testosterone levels that you do see are quite variable. So we think that hormones may still play a role in women. And bicalutamide is also used in women off-label for the treatment of hirsutism and polycystic ovarian disease, which are androgen mediated. And then also in the treatment of, it's been studied at least in breast cancer. And there aren't any new safety signals that would make us think that the drug is more dangerous in women compared to men. Our main exclusion criteria to note are patients who are on positive pressure ventilation or intubated, and then those with significant liver or cardiac disease. Here's the basic study calendar. So we'll be monitoring patients up to 60 days. While they're hospitalized, we'll be getting comprehensive general labs, and then we'll be getting hormone and viral related labs while they're inpatient, but actually also now while they're outpatient. Our primary endpoint is the percentage of people with clinical improvement at day 7 after randomization. So our enrolled patients are going to be these who are people who would be on this mild scale, but hospitalized. And then we're looking to see what percentage of people get to one of these lower rungs. Secondary endpoints are all-cause mortality, measures of worsening disease. We'll be looking at safety and changes in hormone levels, viral endpoints, and then also how the inflammatory response is affected. Our statistical plan is based on a null hypothesis that 50% of patients will have clinical improvement at day 7, and that's based on our internal Hopkins data from what we've seen here. Alternative hypothesis that 80% of patients will have clinical improvement, and this gives us 90% power with a one-sided type 1 error of 0.1. do have an interim futility analysis built into, and we're estimating that we'll be starting in 1 to 2 weeks. I will also say that we're also working on another trial combining camostat and bicalutamide. This is going to be in outpatients, and more to come on that later. And then I just want to thank the Recover trial team here of Sam, Boston, Ting, Jen, and Caitlin, and then also the other COVID researchers and many of the presenters here who we've talked to extensively in the development of these trials. Thank you.
Okay, thank you. Excellent. A few questions to come from that. We'll get back to you. We have one final speaker. Dr. William O from Mount Sinai is going to talk about their case series there. I think it's fair to say that Dr. O's center has been, if not the one of the epicenters in the globe, on the globe for this this pandemic. So eager to hear what you have to say.
Thanks, Chuck, and thanks to Howard and Andrea for organizing these very interesting webinars. The last one was also really terrific, and it's been very interesting to see the different approaches here. You can see my slides, Chuck?
Yes.
Okay. So yeah, we've had 14,000 cases of COVID-19 in the Mount Sinai Health System. Mount Sinai is an 8-hospital system in New York. It's primarily in New York City. We have not been able to query the entire database. That's inpatient and outpatient. But what we did do was look in a preliminary way at all of the patients that we could identify who both had prostate cancer, a prostate cancer diagnosis, either by an ICD-10 code, and who are on ADT versus not on ADT. So this is just what we did retrospectively. We identified all patients who had a positive, documented positive COVID test via EPIC in the period you see there from March 1st to April 6th with a known diagnosis of prostate cancer. And we defined ADT as patients who received ADT within the prior 3 months or who had a documented testosterone level that was castrate within the prior 6 months. And the control group we decided to use here were men with a history of prostate cancer, but who were not actively on ADT or who did not meet the criteria for testosterone. And our primary outcome that we were looking at was, in fact, death, but you can see the secondary endpoints, and I'll show you some of this preliminary data. The statistical plan here is noted, and we've looked at various different ways of comparing these cohorts and controlling for known risk factors for death and poor outcomes. We did logistic regression, sensitivity analyses, propensity analysis, and KM curves, which I'll show you what we have. In terms of demographics, they're shown here, and actually these patients were remarkably well balanced. You can see that by age, smoking status, comorbidities, and medications, they were fairly well balanced. And if you look at the disease state, you can tell obviously the men on hormonal therapy were much more likely to be metastatic or locally advanced with a significant p-value. And similarly, they were actually having more comorbid disease, including more pulmonary disease, but the rest of the risk factors were actually fairly well balanced, again, retrospectively assessed. These are our unadjusted and adjusted odds ratios for the 4 outcomes we were interested to look at. And what you see in yellow are not significant, and what you see in green are statistically significant differences. And if you look at the top line, death, you can see that unadjusted, the hazard ratio for death was 0.58. We corrected for age, which is clearly the strongest risk factor. These were all men. Cardiac disease and pulmonary disease, and after adjustment, the hazard ratio becomes more significant, but not with a statistically significant difference, but the hazard ratio is 0.37. The 2 next outcomes were admission to the hospital and oxygen requirements. Both again favored the group receiving ADT after adjustment with p-values that were suggestive of a difference. And then in terms of intubation, again, a trend towards significance after adjustment, but not statistically significant. We did do a propensity score analysis as well as Cox model, and you can see here that the differences again held up even after propensity score analysis for both admission and oxygen requirement. The directionality was the same for all for endpoints, but not significant for death, the worst outcomes. These are our preliminary Kaplan-Meier curves. Obviously, this is a time-dependent variable, and you can see how short the outcomes are. Everything happens in these patients very quickly, and you can see that there's a trend, but not statistically significant in improvement in survival with a log rank test of 0.5. So this is obviously a very small retrospective series. The prostate cancer patients on ADT with an infection seem to have a lower risk of admission and oxygen requirements compared with patients not on ADT. We saw a trend towards lower risk of intubation and death, not statistically significant. And this third point is really obviously the most important one. You know, I'm not comparing this data at all to the prospective trials that were all considered here. We're all worried actually that we're going to have trouble answering prospective studies, because even though we were deep in the midst of COVID-19 not so long ago, our numbers have thankfully dropped off very dramatically. And Chuck and I were talking about doing a prospective trial in Minnesota and New York, but you know, in the end, I think the trials that are going on are outstanding, and we fully would support them. Our goal here was to try to get some conclusions, but ascertainment bias, I would say, is the most significant risk. This came up in the Alimenti study as well. Who's getting tested? How did we find out about them? And even though we have large numbers, in fact, I think our numbers are amongst the largest that we've seen, certainly of the patients on ADT, is our control group the correct one? And we've already had a conversation with our colleagues at the New York Cancer Centers as well as UCSF to pool a larger group together using our data dictionary, and to see if we can actually make some conclusions around this using a case control approach. And I just want to highlight the key people who did this work. Vaibhav Patel, who's fellow, who will be graduating in a week via Zoom, and will be a faculty member at Mount Sinai, and Tony Zong, the statistician. So thank you.
That's great. Congratulations to both of you, and thank you for the information, William. Really interesting data. This brings up a couple issues that are perhaps Bill Dehat can address. One is that we may see more of findings emerge as sample sizes go up, William, from your study, and I know that CTEP has a study. Dr. Dehat, can you address that for us? What's the status of that?
Yeah, thanks, Chuck. So, William, that's really interesting data, and you're right. That's probably going to be one of the largest, sample sizes around. So, when clinical trials accrual fell dramatically in the spring, there was actually, money available, and so for the first time, CTEP is actually funding a natural history study, and really any patient that is COVID positive, with cancer is eligible. So I would really encourage, everyone out here that's part of the CTEP extended network to open this trial to begin getting some funding for really natural history. And actually Doug Fig from our group actually reached out to Larissa Corday to actually ask this very same prostate question, what's really the status of prostate cancer patients in cancer center? How does it differ? And I think it would be important then for individual cancer centers then to go back to their cancer registries and look at the overall incidence. So if we can enroll COVID, again, looking at the numbers of COVID-19 positive patients, but basically anyone with cancer who's COVID-19, enroll them on the CTEP trial, get paid for it, we'll be able to collect blood, serum in a central way and data, and then combined we can get some information. And again, we're having some interest in prostate cancer, but actually for you who are, division directors like William and Chuck and others, this is for all your cancer patients. So this is just a little heads up on a study.
Yeah, I believe we're in process of opening that up here. I want to call on Tom Beer from OHSU, who I know is on the call and has raised some concerns about enzalutamide and wanted to talk a little bit about potential risks, I think, in these settings. Tom?
Can you hear me, Chuck?
Yep, yeah. Great.
So I just to be clear, it wasn't me that raised concerns, it was the FDA in response to our application. So we were very excited about the concept that many of the folks on this call brought forward a couple months ago, and developed an enzalutamide randomized study, a small pilot, very similar to what the Swiss and the Swedish group is doing. There's slight differences. We found Pfizer and Astellas to be extremely quick and generous in their support and review. And we got a full clinical hold back from the FDA when we submitted for an investigator IND, which pointed out that we don't have evidence that TMPRSS2 is androgen regulated in respiratory epithelium, and that we don't have evidence of reduced viral entry in respiratory epithelium in response to enzalutamide treatment. And also pointing out that enzalutamide is associated with a risk of seizures, and COVID patients can have CNS complications, and that this was a high-risk proposition with inadequate preclinical evidence. We're trying to find a way to respectfully disagree in a productive fashion. I think the part of the problem is that the review was in the virology group and not the cancer group. And so enzalutamide got viewed as a dangerous cancer drug a little bit. But that's been our experience here in the US. And it's been hard to get the preclinical laboratory data together in the current environment. We've tried and have made some partial progress, but not all the way to what the agency would like.
Yeah,
that's our experience, and we welcome any input or advice after this call from anyone that can help us gather the data that we would need to have to respond.
Thanks, Tom, for weighing in on that. It is an interesting dilemma, if you will, having to dive into clinical trials without the optimal, perfect preclinical work. There have been some people doing preclinical work, and some of that was addressed on the previous call. I think I saw that Nima Sharifi was on this call, and I know that he's done a little bit of work on androgen receptor expression and even therapy and its effect on lung tissues. And Nima, if you want to speak up, let me know. A couple of questions that have come across, very focusing a little bit on clinical trial sort of logistics and regulatory issues. Do we need an IND for the bicalutamide in the Johns Hopkins study? What were any regulatory hurdles that were encountered either in that setting or others? Dr. Handy, do you want to just address that a bit?
Yeah, so our experience, it seems, even with investigators who are doing clinical trials here with other agents, is that the FDA is requiring INDs for, it seems like all, repurposed drugs for COVID. I agree too that since our trial is combined with ivermectin, it did seem as well like the FDA was that our trial was reviewed mostly by infectious disease doctors, because they did not have a lot of questions about ivermectin, even though the dose that we're using in that trial is quite high. And they had a lot of questions about bicalutamide, which we thought was going to be, much easier to get. But we made the argument, using a lot of the data, that we talked about with TMPRSS2, but then also we emphasized the upregulation of estrogen being helpful in acute lung injury. And then they also did ask a lot about including women in our trial. So we did also include all of the examples where bicalutamide was safe and had been used in women with no new safety signals. So those were the major concerns from the FDA. But we did get an IND and did get a study may proceed from the FDA. Great.
Another question comes up about the 5-day course, and I'm forgetting, is that the Swedish study or the Silke Gillison study of 5 days of enzalutamide, and how was it arrived on at that duration, and is that adequate duration, and could patients continue longer if they're achieving benefit, et cetera?
It's our trial that have 5 days in Sweden. Yeah, I would also like to comment on what Thomas was saying about the FDA, and then we had some comments as well from the Medical Product Agency about enzalutamide, and they also asked about the preclinical evaluation of what is the basic for the trial, the rationale for the trial, and we have actually paralleled performed some preclinical studies that is very promising in a 3D lung model with lung cells from a woman, and actually it's showing viral they are spiked with the SARS-CoV-2, and we actually see viral load is downregulated 100-fold by adding enzalutamide. So it's very very promising. So we have added that to the answer to the medical product agency. But about the question of 5 days treatment, we were looking at the half time of enzalutamide, and we saw that it's 10 days in some patients. So probably will have an effect more than 5 days. If we stop at 5 days, we probably have at least 10 more days with some effect with enzalutamide. So we thought it would be enough. Most of the patients that arrive in the hospital with the symptoms will probably go to ICU or are as good as going home within 10 days or something in Sweden. So we thought that if we try to cut off the response on the virus initially and try to get the people out of ICU, and that was the main goal for having 5 days, and also reducing the hormonal effects in men and women as well. So
it makes sense that your effect is going to be either it's going to happen early or it's not going to happen.
Or not at all. Maybe you are too late.
Right. Yeah. Has anybody explored the possibility of aerosolization of either Camostat or any of the other therapies that we're talking about? This was one of the questions that was asked, and I think it's a really interesting one. Given that we're giving an oral therapy and hoping to downregulate something in the lungs, I don't know of any aerosol inhalers that have anti-androgens in them, but I wonder if anybody knows anything different.
Not yet.
There's nothing available, and it would have to start at phase 1 all over again.
Yeah.
So it would, Ole?
Yeah, I think there was a long, at least 20 years ago, there was a small study in patients with lung disease. I forget whether it was just COPD or some other lung disease, where they actually gave Camostat as an aerosolized treatment, and it was actually quite safe. But there's only this very small, not well characterized study. So I guess it all goes back to having to set up these trials really fast. It's basically almost impossible to make it rational for giving a much higher dose than has been approved for the indication, or to administer the drug via a different route than normal. So, yeah.
Interesting. So we're in the last minute or so here. I think I'll kick it back over to Howard and see if you have any final thoughts.
Before I have a final thought, I'd like to just say hello to Dr. Sharifi. And if there was a point, Nima, that you wanted to make, you should make it before we close.
Okay, yeah, so I think Tom and Chuck had mentioned some of the preclinical studies. So in the last session, I mentioned the mouse trial of enzalutamide that we did. We looked at TMPRSS2 expression and found no difference. But in light of some of the data that were presented by Rule, we're going to go back and take a look at these two and some of the other things that might otherwise explain the difference.
Thank you. And thank you, Andrea. Thank you, Chuck. Thank you, Bill Dayhut, and to all of the speakers. Our gratitude is deep and global, and we're so thankful that there's this critical mass of people working on what seems right now to be an intractable problem. I just hope we can solve the pandemic through oncology, through infectious disease, pulmonology, and all the other disciplines, internal medicine, that can make a difference and clear this up, get it behind us so we can get back to cancer. Some of us, that's kind of a full-time job. And, hopefully the issues related to COVID-19 won't set our oncology goals back too far. But we are so happy, so pleased that really the world is focused on coronavirology from every possible direction that we can imagine. So thank you all. Andrea, if there's anything you'd like to say in closing.
Thank you. Thank you to all of our speakers. Thanks, everyone.
And we will be distributing and posting the not only a transcript, but the entire webinar tonight. You can find the other one on the internet as well. Andrea will point you to both of these documents that should be up in the next few hours. And we thank you all very much, and stay safe wherever you are.
Thank you, Howard. Take care.
Yeah.
Take care, everybody.
Thank you, everyone.
Thanks, Howard. Andrea. Thanks, everybody.